Welcome to the Deep Dive. Today we're plunging into something really fascinating, the history of healthcare quality. And you might be surprised where it starts.
Oh, yeah. Where are we going?
Way back. Think ancient Babylon, around 1700 BC, King Hammurabi.
Hammurabi's Code, right? Famous stuff. But for healthcare.
Absolutely. Etched onto this huge stone column were laws for, well, everything, including medicine, and they were serious.
How serious are we talking?
Okay, listen to this. Law 218. If a physician performed a major operation with a bronze lancet
Yeah.
and has caused the death, or he opened the eye socket and has destroyed the eye, they shall cut off his hand.
Wow. Yeah, that's intense. Talk about high stakes.
Exactly. So even back then, there was this drive to, enforce some kind of quality.
Though it seems like a pretty harsh, blame-focused way to do it, doesn't it?
Totally. And that idea, just blaming the doctor when things don't go perfectly, it's kind of stuck around.
Right, but it ignores so much, like how sick the patient was to begin with, or the limits of what medicine could even do back then, or even now sometimes.
Precisely. Medicine is often called a soft science, isn't it? There's a lot of subjectivity.
For everyone involved, yeah. Patients, doctors trying to figure out if something actually worked.
Which brings us to the big question for this deep dive.
Yeah.
How do we actually measure healthcare quality, in a way that's meaningful and objective beyond just chopping off hands?
Uh-huh. A much better approach, hopefully.
So our mission today is to unpack the work of three modern pioneers who really built the foundation for how we evaluate care, especially in surgery and health systems. We're talking Ernest Amory Codman, Avedis Donabedian, and Shukri Khuri.
Three huge names in this field.
Our goal is to pull out the key insights from what they did and understand why their ideas are still so vital for the healthcare you get today.
Okay, so before we dive into them, maybe we should set the stage with the definition. What is healthcare quality, officially?
Good idea. The Institute of Medicine, the IOM, defines it as, let me get this right, the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge.
That's the benchmark. Increasing desired outcomes based on what we know works. Makes sense.
Right. So let's start with pioneer number one, Ernest Amory Codman. Born 1869, Harvard Medical School, Massachusetts General Hospital, MGH.
And quite the character, from what I've read. Described as independent, stubborn.
But a creative genius. Even early on, he was doing interesting stuff like studying X-rays, mapping out joint motion using cadavers.
But his big idea, the one that really made waves, came around 1900. He called it the end result idea.
The end result idea.
Yeah.
What was it?
It was pretty radical for the time. He basically said every hospital should track what happens to every patient after treatment.
Every single one.
Yep. Study the long-term outcomes. Why? To figure out what works and actually improve treatment.
Sounds logical to us now, maybe, but back then, tracking every patient long-term, that must have seemed, well, almost impossible.
Logistically challenging, for sure. No computers, remember.
Right. And culturally. Doctors weren't exactly used to having their results scrutinized like that, were they?
Not at all. But Codman was practical. He came up with a system. Simple 3x5 index cards.
Index cards. Seriously?
Seriously. He put down patient details, diagnosis, treatment, the results, and crucially, long-term follow-up info.
Yeah, he actually did this.
Oh, yeah. He tracked about 600 upper abdominal surgeries between 1900 and 1910. And here's the kicker. He classified them by diagnosis and by the individual surgeon.
Whoa. Naming names, that must have gone over well.
You can imagine. But the point was, by collecting even simple data systematically, he could see patterns, variations in care, move beyond just stories to actual evidence.
And did it work? Did it have an impact right away?
It did, actually. His data convinced the staff at MGH to start assigning specific types of cases to certain surgeons.
Ah, so they could become specialists.
Exactly. Develop real expertise and then share what they learned. He even created a rating system for fracture treatments looking at anatomy, function, even the economic impact on the patient, rated 1 to 4.
And you said that system is still around.
Parts of it, yeah. The core idea persists. It was about objective assessment.
Amazing. And these weren't just small tweaks, were they? He pushed for bigger changes, too.
Absolutely. His ideas led directly to something still fundamental in hospitals today, the weekly Surgical Morbidity and Mortality Conference. M&M rounds.
M&M, where they review complications.
That's the one. It started at MGH, because of him, and it's still going.
Yeah.
They analyze complications. Was it judgment, technique, management, or just the disease itself?
And that practice spread everywhere.
Pretty much standard across the U.S. now, a direct legacy of Codman wanting transparency and learning from mistakes.
So every time a hospital does an M&M conference, reviewing cases to learn and improve, that's Codman's influence, making your care safer today.
Right. But Codman wasn't exactly shy about shaking things up. He made some enemies.
Oh, I bet. Especially with tracking surgeon-specific outcomes. What happened next?
Well, he really disliked the seniority system for promotions. Based on how long you'd been there, not how good you were.
Performance versus tenure. Still a debate today in some places.
Exactly. So in protest, in 1914, he dramatically resigned from MGH.
Just quit.
Yep. And then almost immediately reapplied for chief of surgery, basically saying, my results are better, hire me.
Huh. How did that go?
Predictably, they ignored him.
But he kept pushing. I read about this famous cartoon.
Oh, the ostrich cartoon, yes. 1915, a meeting on hospital efficiency. He shows this cartoon.
Depicting Boston's fancy back Bay Area as an ostrich with its head in the sand.
That's the one. Symbolizing wealthy doctors making big money without checking if their treatments actually provided value. He even put a caricature of Harvard's president in there.
Gutsy move.
That's me.
And then he asked the audience if they believed in fraud.
He did. Caused a huge uproar, as you can imagine. He was asked to resign as chair of the local medical society. Faced near total social disapprobation, as one source put it.
Basically shunned.
Pretty much. But was he discouraged? Not Codman.
What did he do?
He opened his own small private hospital right in his house to prove his efficiency theories worked. He literally walked the walk.
Incredible. And he started that bone sarcoma registry too, right? Which still exists.
Yes, under the American College of Surgeons now, still collecting data, just like he envisioned. His commitment was just unwavering.
Then came that moment in Halifax, the explosion in 1917.
A truly terrible disaster. But Codman's response was heroic. He packed up his entire hospital staff, equipment, even his end result cards.
He brought the cards. Yeah.
Rushed to Halifax to help the wounded, organize relief. It was a huge effort.
And Halifax still sends Boston a Christmas tree every year to remember that help, right?
They do. It's a lasting connection. And that act, plus his relentless focus on quality, started to turn the tide.
People started listening.
The founders of the American College of Surgeons, the ACS, started to respect him. He convinced a key figure, Edward Martin, about the need for quality monitoring.
And that led to?
He was made chair of the ACS Committee for the Standardization of Hospitals back in 1912, and that committee eventually grew into
the Joint Commission, the organization that accredits hospitals today.
That's the one. His work laid the direct groundwork.
And the final twist, MGH, the place he resigned from in protest.
In 1929, they appointed him consultant in surgery with operating privileges. He held that post until he died. Full circle.
What a story. And the ultimate recognition, maybe.
In 1996, the Joint Commission created the Ernest Amory Codman Award specifically to honor contributions to measuring outcomes. Fitting, isn't it?
Absolutely. He saw the future. Okay, so Codman gives us this focus on outcomes, on data, even if it caused a stir. Let's move to our second pioneer, Avedis Donabedian.
A very different background. Born in Beirut, Lebanon. Got his MD from the American University of Beirut, practiced general medicine, pediatrics.
Not a surgeon like Codman.
No. He actually got into the quality side more through administration. He was managing a university health service and realized he needed more knowledge there.
So he went back to school?
Yep. Went to Harvard for a Master of Public Health. But his really huge contribution came later when he was at the University of Michigan.
And what was that?
He developed this incredibly influential conceptual framework. The idea of measuring quality through three lenses: structure, process, and outcomes.
Structure, process, outcomes. Okay, I've definitely heard those terms. They seem foundational now.
They really are. Donabedian's genius was formally living them out, giving everyone a common language.
Can you break those down for us quickly? What's structure?
Structure is basically the setting, the resources you have. Think buildings, equipment, staffing levels, qualifications of the doctors and nurses. The raw materials, sort of.
Got it. And process?
Process is what you do.
Yeah.
The actual steps taken in delivering care, making the diagnosis, performing the surgery, educating the patient, the actions.
Okay. And outcomes. That sounds like Codman's focus.
Exactly. Outcomes are the results. Did the patient get better? Did they survive? Are they satisfied with their care? Mortality, morbidity, patient satisfaction. Those are outcomes.
So structure is what you have, process is what you do, and outcomes are what happens.
You got it. By breaking quality down like that, Donabedian gave us a systematic way to think about it, measure it, and ultimately improve it. It provides the blueprint for designing care delivery.
And he wasn't just looking at the clinical side, was he? He thought broader.
Right. He was interested in the social context, the costs, attitudes, expectations, acknowledging that healthcare doesn't happen in a vacuum. There are always limits on resources, differing public expectations.
His ideas must have had a massive influence.
Huge. They shaped a lot of thinking, public policy, social attitudes around healthcare in the U.S. He became really prominent, joined the Institute of Medicine, National Academy of Sciences.
And did he also get recognition from the Joint Commission, like Codman?
He did. In fact, in 1997, he was the very first person to receive the Ernest Amory Codman Award in the individual category.
Wow. The first recipient of the award named after the guy who started it all.
Exactly. And the American Public Health Association also created an award in his name in 1999, the Avedis Donabedian Healthcare Quality Award. His framework is just that fundamental.
Okay, so Codman pushed for tracking individual outcomes. Donabedian gave us the structure, process, outcome framework to analyze quality systematically.
Yeah.
Now, our third giant, Shukri Khuri.
Right. Born in Palestinian Jerusalem, 1943, displaced in 1948, also an MD from the American University in Beirut, like Donabedian.
Interesting connection there.
Yeah, and his father was a statistician. That background seems really key.
An attunement to numbers, as the source material put it.
Exactly. He trained in cardiac surgery at top places, Johns Hopkins, Mayo Clinic, then recruited to Harvard and the Boston VA.
The VA hospital system.
Yes. He built a major cardiac surgery program there, made the Boston VA a center of excellence, and crucially, he understood computers, which were just becoming powerful tools in medicine.
So he had the clinical background, the stats background, and the tech know-how. A powerful combination.
Definitely. And then came the trigger, the thing that really launched his biggest contribution.
What was that?
A law passed by the U.S. Congress in 1986. Public Law 99-966. It basically ordered the VA, the Department of Veterans Affairs, to compare its surgical outcomes against the private sector.
Okay, compare results. Sounds reasonable.
Reasonable, yes, but there was a huge problem. The VA had no system in place to actually do that. No way to prospectively collect the needed data on a large scale, especially adjusted for risk.
Ah, so Congress mandated something that wasn't really possible yet.
Pretty much. So Khuri led the VA team to build it. In 1991, they launched the National VA Surgical Risk Study.
And that became...
That evolved into the National Surgical Quality Improvement Program, or NSQIP, probably pronounced NSQIP by most.
NSQIP, I've heard of that. That's a big deal, right?
A huge deal. They leveraged the VA's early electronic health record system called VISTA, built a massive database over 1.4 million cases initially. It was pioneering work for its time, using electronic data like that.
And what was the core insight that came out of all that data? What did Khuri figure out?
This was his really critical contribution. He proved, with data, that surgical outcomes weren't just about the surgeon's skill or the team's performance. They depended massively on the patient's condition before the surgery, their preoperative risk factors.
So how sick the patient was going in mattered a lot.
A huge amount. And that led to a major shift. If you want to improve outcomes, you need to account for that initial risk. And even better, you could potentially improve outcomes by getting patients healthier before they even got to the operating room.
Optimizing the patient beforehand makes sense. But that also raises the question, doesn't it? If one hospital treats much sicker patients than another, how can you compare the results fairly?
Exactly the problem Khuri tackled. How do you level the playing field for comparison?
And his solution.
He and his team developed the observed to expected ratio, the OE ratio, for mortality and morbidity.
OE ratio, how does that work?
Basically, using all that data, NSQIP could predict the expected rate of complications or death for a patient based on their specific pre-op risk factors. Then you compare the hospital's actual or observed rate to that expected rate.
Ah, I see. So if your observed rate is lower than expected for how sick your patients are, you're doing well.
Precisely. It gives hospitals a fair, standardized way to compare themselves, knowing that the patient's baseline risk is factored in. It allowed for meaningful benchmarking.
That's clever. It moves beyond just raw numbers.
That's crucial. True quality improvement needs that risk adjustment.
And the impact. Did NSQIP actually lead to better results in the VA?
The results were staggering. Since NSQIP started, 30-day mortality after surgery in the VA dropped by 47%.
Wow, nearly cut in half.
And morbidity, meaning complications, dropped by 43%. Huge improvements in patient safety and outcomes.
So if you're having surgery today, the fact that hospitals are so focused on your preoperative health, or that they benchmark their results against risk-adjusted standards, a lot of that comes directly from Khuri's work with NSQAP.
Absolutely. NSQIP became the gold standard model for continuous quality improvement in surgery, adopted well beyond the VA now. Validated, peer-controlled data driving real change.
Sadly, Khuri passed away relatively young, didn't he?
He did in 2008, but his legacy was cemented. Just 2 days after his death, the Joint Commission announced he was the 12th recipient of the Codman Award.
And another Codman Award winner, joining Donabedian.
Right. He'd also received a major federal medicine prize earlier. His impact was undeniable.
Okay, so we've got Codman, Donabedian, Khuri, three giants, three different angles on quality. What ties them together? What's the bigger picture here?
It's fascinating when you look at the connections, isn't it? All three spent significant time in or around Boston and Harvard.
Right, the Boston connection is strong.
All three were recognized by the Joint Commission either through its origins or by winning the Codman Award. And all three faced pretty significant adversity professional battles for Codman, war, and displacement for Donabedian and Khuri.
And you mentioned both Donabedian and Khuri graduated from the American University of Beirut and passed through Jerusalem.
Yes, another interesting link between those two.
So beyond the biographical links, what was their shared vision fundamentally?
I think it boils down to a couple of things. First, the idea that excellence in medicine comes from coordinated, expert teamwork, not just lone geniuses.
Okay, teamwork.
And second, the absolute power of systematic, objective measurement, taking that soft science of medicine and finding ways to quantify quality, track it, and improve it based on data, not just opinion or tradition.
Bringing objectivity, which takes us all the way back to the beginning.
Yeah.
Back to Hammurabi.
Exactly. What Codman, Donabedian, and Khuri collectively showed us is that Hammurabi's approach, just blaming and punishing the doctor, is fundamentally flawed. It's not an effective way to improve healthcare.
It might even be counterproductive, driving problems underground.
Could be. Their work points in a totally different direction. Focus on the system, use data, learn continuously, adjust for risk. That's how you drive real quality improvement.
So when you, our listener, interact with the healthcare system today, maybe you see hospital quality ratings, or you fill out a patient satisfaction survey, or your doctor talks about managing your risk factors before a procedure.
You're seeing the legacy of these pioneers in action. They fought battles, built frameworks, crunched data to move us away from simple blame towards a system that genuinely tries to learn and get better.
It shows how far we've really come in making care safer and more effective. It wasn't easy, but their work laid that critical foundation.
Absolutely. It's a journey of continuous improvement.
Which leaves us with a final thought to chew on. If these giants taught us that objective measurement and fixing systems, not blaming individuals, is key, what comes next?
Good question.
What's the next frontier in healthcare quality? What future challenges might need new pioneers, new frameworks that go even beyond what Codman, Donabedian, and Khuri gave us? Something to think about?